You're listening to the Beyond Nurse Residency Podcast, an educational series where we interview experts on all topics related to the transition of new graduate nurses into practice and beyond. I'm your host, Nicole Weathers, Director of the Iowa Online Nurse Residency Program. Thanks for joining us. Let's jump in. When our new graduates discover they'll be completing what we call a professional experience, but what many of you might call a residency project as part of this program, I often see them grimace and look like they maybe want to run in the other direction. For many, the idea of using research to inform our practice and being a part of making this type of improvement brings back stressful memories of nursing school. But it really doesn't have to be that way. Incorporating evidence-based processes and procedures into our nursing practice is a fundamental responsibility of every registered nurse. It's not just an extra step we're being asked to take, but it's an integral part of what we do and who we are. In this episode, we're going to take a deep dive into the world of evidence-based practice in nursing. We're going to talk about what it is and how it's maybe evolved over the years. We're going to talk about the Iowa model as a framework for evidence-based practice, and we're going to discuss the differences between some of the change methodologies that are out there, including quality improvement, evidence-based practice, research, and even innovation, and how to choose the right approach for your project. I know supporting new graduate nurses in these residency projects or professional experiences can be really challenging, especially when it comes to providing that right level of support without taking over. So we're going to ask our experts on the call today to share strategies and tips to effectively guide new graduates in this process, along with so much more. My goal for this episode is for our listeners to walk away with practical tips and strategies to support evidence-based practice in their organization, especially when it comes to their new graduate nurses. So I have with me today two very special guests, Dr. Kirsten Hanrahan and Dr. Laura Cullen from University of Iowa Healthcare. So why don't we start off by having both of you give our listeners a little bit of an introduction and background to who you are. So Kirsten, why don't we start with you?
Yeah, great. Thank you so much for inviting us to do this. So I'm Kirsten Hanrahan, and I am the Director for Nursing Research and Evidence-Based Practice at University of Iowa Healthcare. I have spent most of my nearly 40-year career here at University of Iowa Healthcare in a variety of different roles. So in the last 8 years, have been in this director role, and really have had great opportunity to work with this team.
All right. And Laura, how about you?
I'm Laura Cullen, EVP scientist in the Department of Nursing in the Office of Nursing Research and EVP. And I have been at Iowa for quite a while as well. It's really quite a unique culture and climate for nursing, and I love that. I have worked elsewhere, but have been here for a long time with leading evidence-based practice. I really love this because I get to work with the best of the best and get to help nurses, help patients, and really cross patient needs from the tiniest babies to the most elderly, and love the variety that nurses bring forward opportunities for us to make improvements. So it's just a privilege to get to do the work, and really thrilled to get to talk with you today.
Excellent. And I guess I've never really thought about the fact that in roles like the two of yours, you really do get to cross all patient populations and work with all different kinds of nurses. And I think that's just a really special, like you said, opportunity. And helping bedside clinicians really improve the care for our patients is just, it's got to be a really rewarding thing that you get to do every day. So glad for you guys to be here. And so in this episode, we're talking all about evidence-based practice in nursing, specifically when it comes to nurse residency programs and supporting new graduates and other clinicians in these efforts. So I thought, who better to have on the podcast to talk about this than the two of you, because this is literally what you guys live and breathe every day. And I think Iowa has some really, really cutting edge things happening in this area. So I think to kick things off, it would be important for our listeners to make sure we're sort of all on the same page about where we're coming from when we talk about evidence-based practice. So maybe you could start by giving us kind of a brief overview of what evidence-based practice is and how it sort of has evolved over the years.
Yeah, that's a great question and a good starting point. There are a variety of definitions of evidence-based practice, and they all basically have three components to it that were developed by Sackett decades ago. And those three components are combining the best evidence, patients' preferences and values, along with clinical expertise to create recommendations for practice. We use the Sigma nursing definition for evidence-based practice in our organization. That definition is that evidence-based practice is the process of shared decision-making between practitioners, patients, and others significant to them based on research evidence, the patient's experiences and preferences, clinical expertise or know-how, and other available robust sources of information. So we use research, certainly, but we also have to sometimes be creative in using other kinds of evidence when we're trying to actually find the answer to the clinical questions that nurses bring forward. And they're really fascinating. It's also been really interesting to see how this field has developed over decades. And Kirsten and I have had the opportunity to see the evolution over the last few decades, but evidence-based practice has been in the works for actually quite a bit longer. And I think of the early work starting in the work of Florence Nightingale, giving her credit for initiating this data-driven approach to designing what practice should look like. That work led in the mid-1900s to a number of disciplines doing work in silos. And I think the siloed work is partly the way we share information within a discipline and siloed across disciplines. So the work in the middle of the last century was led by psychology, sociology, education, and nursing and epidemiology got into it really much more heavily in the early 70s. But it has evolved, and nursing used to call this research utilization, but realized that it's more than just using research in practice. And the term of evidence-based practice really helped reflect those kind of additional elements that you have to think about other than just best evidence. So bringing those together has been helpful. And then the science has evolved in the mid to late 90s. What became known as implementation science developed. And we're bringing this science in to cross and connect the silos so that we aren't as isolated, but in doing so, everybody's bringing their own language to the table. And so we still, as a young science, are trying to figure out what the language will be, what it's going to look like, but continue to really support those three elements being brought in, where nurses have expertise and experience with individual patients that's relevant throughout the process and important to consider.
So I just want to take a minute and just kind of reiterate a couple of the things that you said in this, just because I think it is really important to emphasize this for our listeners, because I think a lot of times when people think about evidence-based practice, we think of the research, right? We think of maybe what was traditionally that research utilization. And the fact that you shared this definition and reminded us that we do want to take into consideration patient preferences, clinician expertise, and other areas of evidence, and not only what the research says. And I think maybe as we get into this conversation a little bit and we talk about some of the other topics that we have outlined for today, we'll begin to see kind of the importance of, when there isn't research available, then what do we do to really meet the needs of our patients? And I think the other thing that I guess I hadn't maybe given a ton of thought about is just kind of how this has evolved since the Florence Nightingale era. So this year, actually, I don't know if you guys know this, 205th birthday of Florence Nightingale. And so we talked a little bit about this on a previous podcast. We were talking about how her legacy still impacts nurses today. And I think this is another great example of what this looks like. So her desire for this data-driven care all those years ago is really what maybe our modern day evidence-based practice is really being based on. I just love that you gave that history, and we are all sort of at the same starting point for what it is that we actually mean when we do talk about evidence-based practice.
What you're making me realize that we don't talk a lot about is incorporating the perspective of what we call in implementation science the local context. So those nurses on the ground at the front line understand their setting, understand their team, understand the patients that they care for, and that's part of that clinical expertise that they bring to the table. When we're designing practice changes that are evidence-based, we need to make it fit and feasible in that local setting. So that clinical expertise that nurses have, because we're here 24/7, 365, is critical to bring to the table. So I appreciate your identifying that.
Yeah, and I mean, I think now that you're even saying this, it has me thinking a little bit more about our residency program and the fact that there's a lot of evidence out there that says nurse residency programs are very effective in retention of new graduate nurses, but how that program is applied in all the unique settings where new graduate nurses exist is going to look very different, right? And what works for a large urban hospital like University of Iowa Healthcare might not be what works for a small rural critical access hospital, in the middle of Northwest Iowa. So I really like that emphasis on local context and the fact that the nurses or the nursing professional development practitioners working in those specific areas are going to have a little bit of say, I guess, in what might be best in this given situation. So I attend quite a few conferences, and it never fails that at least one person will walk up to me and say they use my model for evidence-based practice. And at first I was a bit confused. I was like, well, what do you mean I don't have a model? But then I realized they were talking about the Iowa model of evidence-based practice. So maybe you could share a little bit about the Iowa model, what makes it so unique, and how maybe it's influenced, how Iowa and the Iowa model has influenced EBP on a larger scale.
The Iowa model was one of the early models to support evidence-based practice and is based on Rogers' diffusion of innovation theory. So we have that unique grounding in theory that has helped and actually has been persistent. There continues to be support for the work of Rogers and that diffusion of innovation theory. So having that grounding has been really helpful. And the Iowa model then used that theory to help design the steps in the evidence-based practice process. And those steps we see across the Iowa model. That what we find actually as the science has continued to evolve, and one of the things that I'm completely fascinated about is that the science on sustainability that comes from implementation research actually supports all the steps in the Iowa model. So it continues to be grounded in the science, and it continues to be supported by the science, which is really helpful. What's changed is the way that we develop tools behind every step. So in order to make the steps in the Iowa model actionable, we have tools for every step. And what we include and how we've designed those tools have evolved because the science has evolved. So we keep making the model actionable. The model itself was most recently updated in 2015. So we've looked at that periodically. But then how we use the steps in the model, we keep tweaking as the science advances so that we can make it increasingly actionable, increasingly feasible, and build momentum for adoption and sustainability, because those are our key outcomes from the Iowa model. We're fortunate that the Iowa model has been around for so long and is most used among magnet organizations, but it's also been picked up and requested in 74 countries. around the globe and requested about 15,000 times and cited over 1,800 times, even with translation. So it is widely used, and it's when nurses compare the models, the thing that I keep hearing from them, from our frontline nurses, is that it makes sense. I can see how I can work one step to the other. There's enough information there so that I can see that I'm going to progress steadily. But then the feedback loops also reflect the fact that the process is messy. And how we're going to start initially might lead us to question other things or cause us to do what we call midstream corrections, so that we have feedback loops in the model and don't assume that our steps are linear, because they're not.
Okay, so I think it's really interesting that you bring up all of the tools that are available through the Iowa model. So definitely looking at the Iowa model, it does walk nurses through the process step by step. But I think one of the other really key things, and maybe why it has been so widely adopted by so many people across the globe, is the fact that it does have these complementary tools that users can use as they are going through the process. And are these some of the things, when you talk about some of the updates and things that have been done to the model, or is this really where you see a lot of the new things coming in, is in these actual tools?
Most of the updates are in the tools. The most recent update to the model itself was focused largely on the bottom half. And that's because that's where the science had developed, where we were learning details about how to design practice changes, how to promote implementation, how to get to sustainability. The evidence for that had changed considerably since the most recent version. And so those updates were intended to really beef up those sections to try to provide a little bit more guidance. We know in general that evidence-based practice is provided about 60% of the time, and about 30% of healthcare is waste, and about 10% may be ineffective. So we still have opportunity to improve care and to improve use of evidence-based practice, but getting to the point where we can design it for fit and feasibility so that it is adopted and then sustained continues to be an opportunity for us. And nurse residents are in a nice position because they've got some protected, focused mentoring and work time. So they're able to also bring a really fresh lens. I find it's important when you're new to a clinical area, the questions that you ask are kind of like, oh, wow, didn't think about it that way, when I've been in that clinical area for a while. So their perspective can be really valuable. And I would never want to lose the questions that they bring because of that.
And I love that you point that out, because we do hear from new grads a lot of times. It's like, I'm new. What possible value can I add to a practice change? Or nobody's going to want to listen to me because I am new. So we do really try to emphasize, though, the fact that they do have this very unique lens, and it's one of those things where they're questioning it because it's not the way it's always been done for them, because they're new, right? So that sort of sacred cow, this is the way we've always done it, this is why we continue to do it this way, just maybe doesn't exist so much for them. And so that's one piece I really appreciate about bringing new graduates and introducing them to this type of work, is because they have no sacred cows to kind of hold on to any as they go through the process.
And when we can embrace that fresh perspective and the questions that that brings, that creates a climate for us that can be really empowering.
And I think when you have that opportunity to do that as a new graduate, it's easy to continue to want to engage in that kind of work. I think historically, like for me, for instance, residency wasn't a thing that was available. And I didn't really even get introduced or the opportunity to engage in any of this until I was probably, 4 or 5 years into my career as a nurse. And then at that point, it almost had almost gave me the mentality of like, oh, well, this is just an extra thing. Whereas when we introduce it to new graduates, it's just a part of their role from the very beginning. And so you don't have that like, oh, now you're asking me to do one more thing sort of mentality.
Yeah, I love that, Nicole, because it really is, and the residency programs are building that climate and culture, across all of these settings to say, yeah, it's good to question practice. It's good to bring your perspective. It's good to ask those questions because that's what advances us.
It's good to ask why, even if it might annoy some of your more experienced coworkers if you ask why too much, but it's a good thing to ask why and to really understand why we do things the way we do it. And is there evidence to say that this is the best way? And so I think, like I said, instilling that into new grads from day one is going to help us down the road. So when I first started in this role, I was even myself pretty new to evidence-based practice, especially when it came to supporting other people to work in this area. So we had new graduate nurses who were choosing between doing a quality improvement project or an evidence-based practice project. Some even sort of attempted to kind of go down the research route. But fast forward 10 years, and now we're considering even innovation as another possible route for engaging new graduates in a change process. So with all of these different sort of change methodologies, I think it can get a bit confusing because we have new grads say, well, like, is this quality or is this evidence-based practice? Or like I said, they are trying to do their own sort of little mini research project. So maybe you could talk a little bit about these different approaches, where they intersect, how one can decide which route to take. What does that look like?
Yeah, absolutely. There certainly is some confusion out there, and Laura's already alluded to, just even confusion in the language and such. But I don't think the process itself needs to be confusing. It is great for us to have lots of different methods for problem solving. And I think we can all agree on that. All of these are valuable, but in the right context. So foremost, in considering what this is, research, evidence-based practice, quality improvement, or innovation now, I think it's thinking about what is the project intent. And there are 4 questions that really will help us to get to the intent. The first is with regards to the project scope and what are the boundaries of the project. The second is what is the project's purpose. Third is what evidence is available to guide us. And then lastly, who is most likely to benefit from this practice change? So when we think about this, then the intent of research is really about creating new knowledge that can be generalized. And the benefit really then informs the scientific community. So if I think about a research process, it really fits with new clinicians. So we look more for new graduates to have their intent align more with local improvement, which is for patients and clinicians and the organization. That's EBP and QI. And if the evidence is well known and the process, workflow, or experience needs improvement, we think about quality improvement. But if you need to search for the evidence to guide the practice change, then think about evidence-based practice. And mind you that the evidence doesn't need to be perfect. It rarely is. But it needs to be at least sufficient to guide that practice change.
And I think that's a question, not to interrupt here, but that's a question we get a lot from new grads is like, how do I know if the evidence is sufficient?
Yeah. Well, I think that's a great question. And, to me, for a new grad, you don't know the evidence. And so that kind of points me in the direction of evidence-based practice and understanding that evidence first, and then using what you've got to guide practice, because you need to make practice decisions today based on your patient's needs, based on their preferences, and what we already know from the evidence. So even for something that for a more experienced nurse might be a quality improvement project because they know the evidence, for a new graduate, a new clinician, it might be worth going through an evidence-based practice process so that you have that understanding and that foundation.
So, and I'm going to go take you on a tangent here really quick, because another question we get is, so how many research articles do I need? And, within the last 5 years, and some of those sort of constraints that they come out of nursing school sometimes thinking that there's like this magic number. So maybe you can talk a little bit about that.
Yeah, and absolutely. The definitive answer is it depends. It depends on the strength of that evidence, the direction of that evidence, the risks that are involved, the benefits that our patients are seeing. And so it's really weighing a variety of different methods so that we can understand all of these components of it and do away with that 5-year rule, because there's a lot of really important research and discovery that happened a while ago. I mean, just the things we've been talking today, a Florence Nightingale, back to some of the early definitions of evidence-based practice. There are certainly landmark cases and landmark research that we don't want to miss out on.
Can I just speak to the 5-year limit? We actually are beginning to write a column addressing this. And I think the 5-year limit has potential benefit when you're in doing a coursework for academia. But setting a 5-year limit is an example of where there's actually added risk to the clinical setting. It's an arbitrary limit. It doesn't reflect the fact that our science is so longstanding. It doesn't reflect that many of the clinical issues we have today are longstanding. It doesn't reflect that there will be gaps in research windows that if you limit arbitrarily, you could miss some key research that would be informative. The other thing that it creates problems for is also thinking about the type of evidence. So there's times that case studies can be critically important in helping you design a practice change. And there are reports of case studies from research that were missed and contributed to significant and bad outcomes. So understanding that evidence in a more complete way is much more important than thinking about setting arbitrary limits for the type of literature you want to look at, or the number of years you want to look at, or even the patient populations that you want to be looking at research related to. So it's one of my kind of bees in my bonnet, which is why I just wanted to take that tangent just a little bit in thinking about the evidence more broadly.
And I think as a student now, because I am currently a student as we're recording this podcast, and I see where it is helpful on the student side, just to, like you said, give a little bit of parameters to help a student not go too far down the rabbit hole. And I think I'm thinking of my DNP project specifically, which was about, nurses going back to school and continuing their education. In some contexts, and I guess I would love your feedback on this, some of the things that are happening societally, politically, like the current 5-year sort of window there's going to be some impact that is happening within that current 5-year window that might help be a little more helpful for us as we're looking at a project in that area, because there are some factors that might influence that decision to go back to school, like the economy and things like that. So for me, for this project, I did choose to sort of limit that window a little bit, just because I thought that was maybe what was going to be most helpful, versus back in the 70s, right, when people were deciding to go back to school. It was a very different climate at that point.
Yeah, I do think too, sometimes I think about technology and how it has changed. So we did a evidence-based practice project related to central lines. And that was one that we thought, well, the technology for central lines has changed so much. Does it help us to go that far back into the literature? And so we were looking at the more current stuff, but we also wanted to go back enough to understand what changes came about and why they came about. And that also then helped to inform the project. So even though you may set some limits because of the specific nature of the project, I think it's important to also think about, well, what from a historical perspective and historical evidence may be important to informing this so that we're not making the same mistakes over again.
And that's a really good point, right? We don't want history to repeat itself, and like we're continuing to, like you said, make the same mistakes. So I really appreciate that.
Yeah. Nicole, can I round back because I want to bring us back to innovation because you also mentioned innovation, and I love innovation, but I think, the focus on innovation is really for problems that we don't have a solution for or that the current solution is failing. And before we can get to new solutions, we have to understand the current practice and what's not working, what's feasible, what's core to an intervention that gets you to the desired outcome. And so I really recommend still starting with evidence-based practice. That certainly you'll need some creativity and even some innovation in designing that evidence-based change and implementation plan. But for most new graduates, I really recommend that EBP is the best process for learning what's new in the evidence and then also how to apply it and get to improving outcomes.
So what I hear you saying is sort of it always starts with a look at the literature. What is known about this problem? And then based on what is known or setting, what the purpose, the goals are, that sort of help dictates if we would need to generate new knowledge, right? If we need to just fine tune a process within our organization based on what evidence is available, or if we need to bring innovation into the picture.
Yeah, I think that's right. You've got it.
The other thing I think is helpful is what I've seen is when nurses learn the EBP process, that will help them troubleshoot with every other process they're going to use.
Because I think it keeps taking them back to what do we know? What does the research tell us? And using that as a guide. So in our program, we ask residents, of course, to complete what we've called this professional experience. They can choose to do a change project, which is usually quality improvement or evidence-based in nature. They can identify sort of a case study that this is usually a patient that they've cared for in the past. And then they go to the research to see what does the research say about this, situation. A lot of times, maybe the patient had some sort of adverse event. And so they're looking for what could we do differently at our organization to keep this from happening again. And they would take this proposal, if you will, to a unit-based council or something similar to decide if this is something that the facility, wants to tackle, or they can get involved in some existing committee work. But regardless of which route they choose, they need to identify some sort of metric or measurement indicating that there is a need for change, and they need to take a look at the evidence that is available to guide their project. But one of the biggest challenges we sometimes face, and what I think our listeners can really relate to, is how do I facilitate and support this process? Because not all leaders, of course, feel comfortable supporting new nurses through this process. So if they aren't comfortable, it's easy to let the new grad sort of figure it out on their own, and then there's floundering and kind of not knowing which way to go. If they are comfortable, the other thing that we see is that they kind of take over the process, right? And they don't let them do much of it on their own. And then additionally, we've got nursing professional development practitioners that are and nurse leaders that are incredibly busy, and supporting these projects can be pretty time consuming. So I would be curious if you guys have any strategies or tips that you could share so that our listeners can more effectively support new grads in these efforts.
Yeah, well, first of all, this is just such an excellent question because as we know, the role of the leader and the EBP facilitator is, just can't be overstated, both in terms of project success and mentoring. So in thinking about this, I think the first thing to think about is clear roles for the project lead, for the manager, and for the facilitator. So when we think about new grads, they really need to develop that subject matter expertise and lead the project. Managers don't need to be EBP process experts. If they bring that, that's great. But really, their role is empowering those new grads and providing them with the resources that they need, like time, supplies, access to people, connecting them within the organization. And then the NPDs are likely to be the person to facilitate the EBP process and help that new grad and keep them on track using the process. And then other things that I think of in addition to that in terms of tips are just to keep the language clean and the process clean. So not dipping a little bit into EBP and a little into quality improvement and mixing your methods and that. But for these first projects, keep it clean. It's a straightforward EBP process and follow that process to the end and stay true to the intent and that method that you're using. Another tip would be to stick to one model. And, I think in school, you're learning a lot about different models and that kind of thing. But if we're all within our organization using one model, that helps us to communicate and understand the next step in the process and where we're going with this. So sticking to that one model. I also think keeping it simple, learning the process, and getting the win. And so, a lot of times we want to swallow the ocean or eat the elephant, but we need to reel that back a little bit and come up with that small, definitive process, a very well-defined process that we know we can get that win with. And then we can keep adding on and doing iteration and such to get to something more advanced. And then the last tip that I would say is to look at these resources and tools that are available to make the process easier. There are many online resources that are excellent and no cost. Don't waste time reinventing. Instead, take the tools that are out there and adapt them to meet your needs. And honestly, I'm just going to say, don't waste your money on expensive tools. They're not really any better than some of the stuff that is out there and complementary.
I'm going to go back to one thing you said about picking a simple, definitive focus for the project, because I think that is one of the things our new grads can struggle with the most, is that idea of, well, first it's like, oh, do I really have to do this? And then when they wrap their brain around, yep, they're going to do it, it's like they want to solve world peace. And so one of the roles I think that we have leading the nurse residency program, the leaders, the MPDs in the organization have, is to help them scale it back sometimes. And how do we bring it back to a small but simple thing? Because we want them to be successful. I mean, that's the goal here, right? That they learn the process and they're successful so that they want to continue to engage in this kind of work into the future. I think sometimes when they do try to take on this big project, then we know change is a challenge. Getting everybody on board is a challenge. When we run into too many roadblocks and get too frustrated, it's like, this just isn't for me. I don't want to do this. I don't want to finish this, and I don't want to ever do this again. So I think really, especially for these first time new grads in this process, that probably statement can't be overemphasized enough, because I think in order to keep them engaged and keep them wanting to do this work, they've got to have some of those small successes in the beginning.
Yeah, and really that comes back to one of the early steps in the Iowa model. And as Laura said, these are foundational. State the question or the purpose. And that really provides some guardrails around the scope of the project and helps clinicians to focus in. What we see a lot of times with student projects or early residency projects is they want to jump right to the intervention instead of getting into the evidence and seeing what really is the right intervention for the problem that you're facing. So first of all, really going back and making sure you have a clean purpose statement. And then, that may evolve as you get into the evidence, but to kind of create those boundaries around the scope of your project.
Well, and I think another early question in the Iowa model is, is this an important project for the organization? Or I don't know what it actually is, but it's something along those lines. And that is another one that we sort of continue to emphasize for our new grads is do something that matters to the organization, because that's where the buy-in and the support are going to come from. And nobody wants to, I mean, we don't want them doing a project just for the sake of checking the box and saying they did it, right? We want this to have some meaningful impact at the end of the day. And I think that is such a simple question, yet I think one that we often forget to ask. Because we've maybe identified in our own mind that this is something that's important, but if it's not a priority for the organization, I think we really need to reconsider the project.
Yeah, it is an important question. Is the topic the priority? But it's also important in terms of later thinking about how you're going to evaluate the project, because you want to be able to demonstrate back then what made it a priority for the organization, the impact of your project. So it's important up front early to be considering that, but it also downstream has implications.
Well, and I think when we're talking about, measurements to really show, did this change, this intervention, did it make a difference? If we don't have anything indicating that maybe it is a priority for the organization, that's really going to be hard to show. So as we look forward to the future, how do you envision the evolution of evidence-based practice? Do you see any sort of emerging trends, challenges, and how can we maybe begin to prepare to address those?
Well, I think as we look to the future, we have to, first of all, acknowledge our limited resources, and primarily in terms of workforce challenges. We can't keep doing things the same old way and expecting better outcomes. And so instead, we have to really seize this as an opportunity for evidence-based practice. So things I think about in terms of what we need to do are, first of all, considering and continuing to optimize the EBP process with methods and tools that make it easier. We want to think about how we can leverage technology with caution and with clinical judgment. I think using the implementation science to leverage our change, not just the spaghetti on the wall, but really what is it that impacts change is important. And then considering those patient values and partnering with them in co-design. As Laura said, this is the basic definition of evidence-based practice. And then I always think too about de-implementation and undoing the things that just don't work, instead of keep piling it on the work for our clinicians. I think it's important to remain practical and feasible in our real-world settings, and that's why the impact of evidence-based practice is more palpable than in the research world, because it's real. And then lastly, just to continue to develop EBP skills for the next generation of nurses.
This whole idea of de-implementation, I think, is really something that we as a profession need to highly consider, because I think we're all, it doesn't matter what facet of nursing that you work in. It's so easy to keep adding and adding and adding, and everything is so important. And we never take away, right? We never think, what isn't really adding value? What really isn't making a difference? At some point, we've got to begin thinking about that, because when we're looking at things like some of the issues in our workforce, some of the issues around burnout, things like that, I think de-implementation has a really important role in helping us fix some of that.
Yeah, I agree. At the very least, we need to be considering what is effort neutral change. We can't just keep adding on. And so thinking of de-implementation early in our implementation processes, so that, and then that makes decision-making easier too, quite honestly, and makes it easier to do the right thing.
And I love this idea of co-creating with the patient, because I think it's easy for us to think, this is what is best for the patient or the patients that we care for. However, I think that patient perspective is so important to consider as well.
Yeah. And, as nurses, we think we know what our patients want, but the evidence would show quite differently. And so we really do need to ask them and engage with them, and not in a tokenistic way, but in the ways that really matter, that they can help to really co-create, co-design the care that they want to receive.
So I'm curious, what would that look like? So if I was an organization who wanted to engage patients in this process, what are some examples of how that might look?
Laura, I'm going to throw that to you because I love how you talk about your vision for the future of nursing that is patient-driven.
Yes, thanks. My vision is, in fact, that healthcare would be patient-driven instead of clinician-driven, and we've got a long ways to get there. So there are things that we can do in our individual interactions with patients, but also as organizational systems. Certainly shared decision-making with patients, so that when they're choosing the interventions that they want to use to help promote their health, that is one area we need to do that. One example for inpatient care is the engagement for patients for fall prevention, and trying to shift from doing to and doing for, but having the patient involved. So we're doing with the patient for fall prevention. And so whether we're doing it in an ambulatory setting where they're picking the health promotion activity that they want to try to adopt, and whatever that would be the priority given their current health status, then coaching and guiding them along the way to adopt that health behavior. Or when we're in inpatients, we can really address what are their needs. Setting goals that are patient-driven instead of clinician-driven can really change the way we communicate with patients. And from an organizational system perspective, it's building patients into our governance structures so that they're members of committees and can represent the patient perspective in our conversations, in our setting priorities, in our planning for processes, in the way we design our educational materials, for instance, so that we're including them all along the way. That's one of the things we've added to the Iowa model, and our book most recently is tips for patient involvement every step along the way with the Iowa model, because we want to move this direction where patients can become drivers. At a minimum, we're engaging them so it's shared decision making, but getting to where they can lead us to where they want to be.
I love that. And I love the fact that you provide tips in your new book that help organizations figure out maybe what that looks like. So you also mentioned the idea of leveraging technology. So maybe you could talk a little bit about that.
Yeah, well, there is certainly a lot going out there in terms of technology advancements, and that's all great and could provide some solutions to some of our workforce issues. But we also have to be very careful about that and not remove that important critical nursing judgment. And even when it comes to evaluating those technologies and making sure that, we're keeping human touch involved, that it's nursing judgment that is even informing those technologies. And so thinking about how, when, and where we use them will be important. And, and not to just assume that products that are out there have been vetted with nurses, have been vetted with patients, but to really take a critical look at them. And so I think we have a responsibility to our patients to do that as well.
I like that Kirsten brought that up. And would also just add that in other industries, when we bring in new technology, it usually reduces the workload of the worker. But in healthcare, there's evidence that it typically increases the workload of the worker. And one example that comes to mind is the smart pump. I remember going around to patient rooms and counting drips and trying to make sure that the IV rate stayed on track. And, the smart pump is designed to help us with errors, but in that push to get it out and used and then revenue generating from the vendors, it came out really before it was designed for enough safety mechanisms. And early evaluation of smart pumps found over 150 points at which error could be generated because of the smart pump. So we have to be really careful with technology that we're using it in a way that is helpful and that it does, in fact, have the evaluation that Kirsten talked about. And we get that input cycled into it in order to make sure that it's usable for the end user, the clinician. And the other thing that technology makes me think about is the focus now on AI. And there's certainly opportunity with AI, but we're in a very messy phase right now, and we're going to have to be really careful until we can get this perfected. For instance, when we're using data from our own electronic records and language learning and big data, what we know is that the information in our electronic records is actually biased. We don't document the same way for all of our patients. And so we're using biased data to help direct care. So that's important to think about. I think there's going to be opportunity when we're looking at synthesizing evidence and using AI to help us synthesize evidence. But there's a lot of detail in evidence reports that are critical to know so that we can plan to avoid intentionally or at least measure unintended consequences when we're doing practice changes. And we're likely to lose that if we do generative AI to help us synthesize evidence. So until we get through this window where we're missing bias and missing the description of the how that comes from reading research to help us avoid those unintended consequences, our use of AI is going to actually potentially create some additional or new errors that we're going to have to watch for. So lots of opportunity here, but there's always a learning curve.
And I think that's a really great point, because I think we always think of technology and AI as improving safety, saving clinicians time, all of the sort of things I think technology can help with and AI can help with. But like you said, we need to pay attention to some of these other factors and not be too quick to just think technology is going to fix the issues.
Yeah, it makes me think of the cognitive burden as well. Sometimes we get so caught up in the technology and the pumps and all of this, we forget to look at the patient and really to peel that back and keep that focus.
Well, and I think that brings us back to our discussion on Florence Nightingale and going back to the basics, right? Paying attention to the patient themselves and all the important things that she taught us so many years ago. All right. Well, we have talked about so many great things today. We've talked about evidence-based practice, the Iowa model, the difference between quality improvement, evidence-based practice, research, and really where innovation begins to fit in the mix as well. And then we've talked about some tips and strategies for supporting new graduates as they learn and engage in these processes for the first time. So I want to thank you guys both for spending time with us today and sharing all of your valuable expertise that you bring to the table. But before we go, I have one last quick question, and this is something that I ask of all of the guests that come on the podcast. But when it comes to supporting nurses in evidence-based practice, what's one thing that you see organizations doing that makes a significant difference that you wish more organizations would do?
Well, thanks, Nicole. I'm going to try and give the quick answer to that in response. I think it's about investing in infrastructure for evidence-based practice. And so what does that look like? Really, it's about building evidence-based practice into the work that we do every day. And that is seen through things like policies and professional governance standards, strategic plans, those kinds of things. I think it's also important that we're hiring the right people, that we're hiring neuroscientists and EBP facilitators to mentor these projects and people who have that expertise and can pass it to the next generation. We also think about having programs to build EBP skills. And in our area, we talk about it across the career continuum and meeting people where they're at, because it's very different if you're a new grad and are getting some evidence-based practice in your academic content Versus if you're a career nurse and you've got all kinds of clinical knowledge, they didn't teach that back when. And so having programs that can support nurses from that beginning all the way up to advanced skills. And then last, but certainly not least, the biggest barrier is always time. And so thinking about having paid time away from direct care responsibilities for nurses in various roles to lead and engage in evidence-based practice.
Laura, how about you? Any thing that you would like to add as far as what you see organizations doing that really is making a difference?
I completely agree and think Kirsten did a really nice summary of what organizations really need to provide to support our nursing practice to be able to be evidence-based and make the impact that nurses want to make. I think there's always the opportunity to lead. Every nurse has the opportunity to lead and be a leader, and questioning practice and providing positive influence and setting the bar for what we do high is something we want to do across our career continuum. And as nurse graduates, I would just really encourage them to ask questions, because it's really helpful to, whether you've been in the organization a while or whether you're new, to really start peeling back the layers of what is it we're doing, why are we doing it, and is it really the best way we can do things?
And one last question, because you did allude to this as far as, programs to build the skills in our nurses. So I know for a lot of the listeners of this episode, of course, we begin to introduce this in our nurse residency program. But as we said, a lot of our coordinators that we work with, a lot of our nurse leaders, if they're in a hospital where they don't have a Kirsten or a Laura, somebody who's an expert in this work, where would you suggest they could maybe go to learn a little bit more? What sort of resources are out there? I would say specific to the Iowa model, given the popularity and how usable this model really is.
Yeah, great. Well, certainly the World Wide Web has just, a ton of resources and such out there. And we can connect listeners to our website that has a whole list of complementary resources, which includes the Iowa model, our implementation framework, these tools for every step of the process, and through a simple request process, they can get those for free. In addition, we have programs. We have an annual evidence-based practice conference. We're in our 32nd year. It is a national conference, and usually in the spring, that is a great way to kind of get some exposure to evidence-based practice and then bring that back to your organization. In addition, we do provide consultation and external programming for organizations that may not have that kind of internal support. We are very close to being ready to post some kind of foundational modules for learning evidence-based practice. And, we're just one of a number of sources that do that kind of thing. I would think the things that set us apart are ongoing success in this, that our tools are, for the most part, all free, and they're proven. They're proven by use by our clinicians, by that worldwide reach that Laura described, and so proven to be very effective.
Excellent. Well, Laura, Kirsten, thank you again so much for being here with us today. I think evidence-based practice is such an important topic, whether we're talking about new grads or not, and you guys have so much expertise, and we're so thankful that you were here to share that with us today.
Thank you, Nicole. Thank you for all that you're doing for nurse residents. We are going to need them in the future. And so I really appreciate this opportunity to share our perspectives on evidence-based practice.
Agree. Thank you so much.
Wait, before you go, I want to make sure you know all about our suite of resources you can use to support your new graduate nurses. This includes our Academy, a coaching program designed for organizations as they prepare for the implementation and ongoing sustainability of a nurse residency program. Work one-on-one with residency program experts to make sure your organization is residency ready. Our Clinician Wellbeing course is an asynchronous online course that aims to enhance the well-being and resiliency of healthcare professionals, equipping them with the necessary psychological capital to navigate challenges inside and outside of work. Supporting Nurses is another asynchronous online course for preceptors, mentors, and coaches to learn the skills they need to support any new hire. Both of these offerings can be used as a standalone professional development opportunity or to augment any nurse residency program. And we can't forget about the program that started it all, the online nurse residency program. This includes a comprehensive curriculum designed to support new graduate nurses applying all the knowledge they learned in school to their practice. We focus on professional skills, personal well-being competencies, and new graduate nurses even get the opportunity to create real change in their own organization. Offered completely online and in a blended format, this program is highly adaptable to all clinical practice settings. You can learn more about all of these programs and more of what we offer using the links in the show notes below.